I wanted to essentially have a bit of a contrast with perhaps the last and some of the coming talks to talk about a particular example that I was involved in some research with some behavioural scientists when I worked at the University of Cambridge in the primary care unit there. I sort of used this example as a teaching example to Masters in Public Health students as well. And so I wanted to share a bit about the research that I found interesting and a bit about how to explain some of the what can be quite difficult concepts to other professionals who aren't statisticians. So essentially the talk highlights issues that come up in primary care when patients access health through primary care. Populations accessing through primary care are quite different from clinical populations that are perhaps very well defined in terms of the condition that they've come in for. Also, that this particular example speaks to public health type interventions rather than perhaps the more familiar intervention, clinical and drug type interventions that we see in clinical trials units. And also this particular example speaks to outcomes that are more geared towards behaviours and trying to prevent conditions from appearing or getting worse, rather than outcomes that are treatment type outcomes. So behaviours like smoking cessation and other related behaviours like physical activity and diet are other quite common areas where prevention research is done in primary health units around the country, and often involving trials of these sort of interventions, public health type interventions. So this was work I did with two people, Felix Norton, who was studying for a PhD at the time, and his supervisor, Professor Stephen Sutton. And they were interested in doing a review to find out whether a particular class of interventions called self-help interventions might be helpful in helping people to give up smoking, particularly during the period of pregnancy. And so I'll move straight on. It's quite an important area, pregnancy, because there are a number of other outcomes apart from long-term outcomes of CVD and cancer and other major diseases that smoking is associated with. But in pregnancy, listed on this slide, are a number of direct effects both on mother and baby, and from environmental tobacco smoke, from partner smoking and so forth. So it's a very worthwhile area to want to do research in to try and make a difference. And a number of trials had been done, but no one had particularly looked at this class of interventions to try and see whether gathering the evidence altogether, or whether that particular these interventions might be found to be effective. Often in primary care research, these sort of public health interventions occur at an opportunity point, and this was no different. So, for example, when women come in, pregnant come in and see a midwife, that's an opportunity point for the midwife to be able, for example, to introduce interventions that would help smokers to be able to give up smoking if they wanted to at that point. Public health interventions are quite different from many clinical and drug interventions. In many ways, interventions are quite similar in clinical research, or they can be. A particular drug is a drug, and from one study to the next, it's the same drug that's examined. Whereas in public health, often the interventions themselves are built up within the study as part of a program, or perhaps interventions are available and they're developed and tested. And so when you come across literature, the things don't all fall into place in a very neat way. Often interventions get classed into different types. And so, for example, counselling interventions is one class, which involves counselling and face-to-face contact with a health professional on one hand, and then self-help interventions, these other interventions that were of interest to Felix and Stephen, were basically about being provided with information, essentially, either through booklets or text messaging or other means. It's not about competition. I think clinical interventions can be a bit about competition. Is one drug better than another? I think in public health it's more about let's actually find several classes of interventions that will be complementary and be available to women who may prefer, some women may prefer material and not much contact with the health professional, or vice versa, they may prefer contact. Having different options available means that you're going to have interventions that are more attuned to women with different preferences, and also some intervention classes have particular unique attributes about them. For example, self-help interventions about helping yourself with the information you're provided means that you don't have to be anchored with a health professional with lots of face-to-face contact. You can have wider reach with these interventions, and because they don't involve a lot of time with the health professional, they can be much more cost-effective. And also, it's very useful in public health when gathering evidence about interventions. For example, NICE, they like to gather evidence around several interventions so that then they can make guidelines that enables commissioners in different local areas to be able to put together interventions that have been shown to be effective, and that may vary from area to area depending on the priorities. I think the motivation for doing a review, and in particular this one, was that these particular class of interventions hadn't been put together in a systematic review before, so there's a gap. You always need a gap, and as when you do any research in an individual study. And also there was some indication that these might be quite useful because outside of pregnancy the direction of effect was in the sort of positive direction, so that was another good factor for going forward with this review research. With public health interventions, it's also very important to actually define the intervention. Clinical interventions might be drug interventions where the drug is very easily definable. But self-help interventions, they're a sort of class of interventions. There's a bit of heterogeneity within the class. The interventions are defined a little bit differently. Also you want to have a definition that makes sure that the classes are distinct from each other. And so the definition that they came forward with would involve a bit of inclusion and exclusion. So self-help interventions are about providing structured materials, that's the essence of it, to help people to be able to give up smoking, but without having significant assistance from a health professional, perhaps someone there at the beginning to give you the materials. And not too much, and you're sort of working on your own rather than in a group, so it's a definition of inclusion and exclusion. So there can be quite a lot of blurring in public health type interventions that perhaps are more common in primary care research than secondary care and clinical interventions. So there's a bit of heterogeneity of the interventions within the class. That's in terms of several things. The mode by which it's delivered, are the materials intense or quite light? Some interventions in some of the studies that were involved in this review use tailoring within their intervention, which is essentially giving a version of the intervention that's tailored to your particular attributes. Perhaps if you smoke very heavily or smoke lightly, you would get a different version of the intervention. And you can have lots of different combinations of factors, and the intervention you receive can be slightly different depending on your circumstances. And I think tailoring has been present for about 20 or more years in this sort of area of public health interventions. And I think clinical interventions are a little bit behind, because nowadays there's been quite a bit of talk, perhaps over the last 5 or 6 or so years, of personalised medicine. And this is the same kind of idea as tailoring, really, where you're trying to identify a particular variant of treatment that will particularly help you improve in terms of outcomes. The first objective of public health interventions is very much like clinical interventions. It's still about, is there overall effectiveness of these interventions? But an opportunity of public health interventions, you can do a bit more exploration and set up more objectives, and that's what Felix and Stephen did. They set up objectives which tried to explore intensity of materials. Does that actually make a difference within the class? tailoring, does that make a difference? And if it's delivered by text message or by booklet, does that make a difference? That often involves subgroup analyses in meta-analyses, and often subgroup analyses we know in individual trials are underpowered, and they can be in reviews as well, in meta-analyses. And so one of the things I stress to my Masters in Public Health students is that you have to take quite a lot of care. You might see quite wide confidence intervals, relative risks or odds ratios which span quite wide ranges. And the old quote that I think Doug Altman often comes out with, you need to distinguish between absence of evidence and evidence of an absent effect. And I think in meta-analyses, you have to be very careful, particularly in these public health ones when there are more subgroup analyses, that you recognise that wide confidence intervals basically means you need more evidence. Whenever you do research or a systematic review with meta-analysis, I think these are some of the issues that are quite important to consider before you get going and justify to yourself. And I think funders look for these sorts of things as well. You've got to show importance of the area. You've got to show what these particular interventions offer that others don't. You've got to have some inkling that it's going to be effective, because essentially you don't want to embark on a really long systematic review without actually counting the cost and having some indication that there might be a positive effect and something to learn from. So essentially you need to show the motivation for undertaking a review. And essentially that was there is a potential for effectiveness. There is a gap with this particular class, and the result of doing it might be that we might recognise an effective class of interventions and inform the need for implementing it in around the country and helping people's health. And maybe there's not enough evidence there, but that can again inform us to do more research. And I think NICE and the NIHR are much more linked up over the past 5 or 10 years in public health research. When NICE reviews evidence for guidelines, they often find gaps, and that gets passed on to the NIHR, who can choose to prioritise that and ask for calls for research in that area. So I think, and then I think the NIHR public health research stream have been going about 5 or 6 years, and now trials are beginning to come out the bottom end, so they're going to feed back through to NICE, who will have more evidence. A really nice acronym that probably many of you know is PICO. So I mentioned this to the students. These are a very key acronym that helps us in various ways. Often gets extended to PICO, PCOS, PCOST, and so forth, depending on what you add on the end. But often, as statisticians, we tend to use these 4 elements when we write any of our statistical null hypotheses that relate groups. PICO also comes up when you want to define a research quest in a single study. It needs to be defined by these 4 key elements of patient population, in this case pregnant smokers, intervention, self-help interventions, the comparator, which is usual care, and the outcome, smoking cessation in this case. Felix and Stephen wanted to focus on RCTs, and so the S sort of represents the study design. And this acronym is also useful within systematic reviewing, because if you want to know which studies are relevant for your systematic review, you need to apply these as eligibility criteria. So these are quite key elements of the eligibility criteria. So out of the 3 of us that were working on this project, I was the lucky one, because the other 2 had to do this particular effort, the effort which is on this slide. And this slide represents a lot of effort, as many of you probably know who have done systematic reviews. So they identified around 1,000 studies, and they managed to exclude quite a lot of them just by having to look at the title and abstract. And that left just under 50 for them to look through in more detail. And they applied the eligibility criteria and came down to 12 trials that would answer the primary objective. I think there were 3 further trials that could be used for the other objectives. But one issue that came up, that there was a trial that included 25% of the women in the study who had already quit smoking by the point of recruitment. So you begin to wonder, what's the point of trying to help people quit smoking if a quarter of them have already quit smoking or reported doing so at the beginning? And so Felix contacted the authors and said, can you strip out the people that already quit by recruitment so that we can do our review in those that were able to quit post-recruitment? But It's a good thing to ask authors, but on this particular case they didn't respond and give us that data. So the big quandary was, should we include this study or not? And they decided, be inclusive, let's include the study, and define a sensitivity analysis which would drop the study out if and see what the impact is. So that was one aspect that I wasn't particularly expecting. The data from the 12 trials is displayed on this particular table here, and the years span way back from 1985 up to about 2003. And there were some quite interesting features in the data. There were some studies with very small denominators of maybe 100 or 200. In fact, 7 out of the 12 studies had fewer than 300 people in the study. And it turned out that to detect a doubling of the quit rate, you'd need about 850 in the study to have 80% power. So a lot of them are underpowered. And a lot of them had very few events, which contributed to the underpowering as well. We had to use a continuity correction because some of the studies had zeros of people quitting in some of their arms. And the events were pretty low, around about 5 to 10%, reflecting the fact that it's very easy to take up smoking, but very hard to quit. The trial that included the baseline quitters was the penultimate one listed there, and that had a higher rate of quitting smoking by the end of the trial. And we felt that's probably not surprising because it included 25% of people that reported having quit at the beginning of the trial, so that bumped up its particular event rate. The forest plot is a very key plot in meta-analysis, displaying the effects from the studies and our uncertainty about those effects are the sort of whiskers coming off the black squares. Very first study, when I teach this to students, they get quite excited because they say, oh, it's an odds ratio of 7, that's very large, it's statistically significant, that's really good, isn't it? But actually, if you look at the breadth or the width of the confidence interval, it ranges from around about 1.5 to about 26 for a sort of odds ratio way up this end of the room. So really, it's an example of the study that might be exciting in terms of a clinically important effect, statistically significant, but there's very little information in that study, and I think that's quite an important thing to bring out in meta-analysis, is to keep an eye on what information is there in the study. But gathering all the information together, the evidence across the 12, the diamond sort of represents the pooled effect at the bottom, 1.83, just under 2, so odds ratio, so you're about twice as likely to quit smoking or a bit less if you're on one of these self-help interventions compared to not being on one. Quite a bit of heterogeneity. You probably noticed that the black squares are really varying a lot left to right. There's a lot of variation around that pooled effect. Cochrane's Q statistic, a key statistic in meta-analysis, is 28 on, I think it's about 12 degrees of freedom, with a p-value of 0.002, highly statistically significant heterogeneity. I-squared, a measure of quantifying heterogeneity of around 62%, quite a lot of excess heterogeneity from what we would expect to see. What is heterogeneity? Well, it sort of measures lack of consistency in the findings across the studies. Wouldn't it be great if all of the studies lined up one under the other with their estimates? That would be much nicer, wouldn't it? Because then we'd have a lot more faith in our findings. But I think, as you saw from the previous plot, that wasn't the case. Between study, variation in the estimates is how we measure statistically heterogeneity. And it may represent chance differences. I say to the students, there's a P was 0.002, 2 in 1,000 chance that we'd see something scattering like this or worse. But that's a very low p-value and unlikely. We have to consider other factors. And we can sort of categorize these factors into the PICO acronym that, you know, a lot of these studies are done in different countries from each other with different health systems. There are different eligibility criteria applied, and this very peculiar one, which included quitters at the beginning. The quit rates themselves varied from around 4 to 18% across the studies, so that obviously represents something different about the populations. In terms of the interventions, the constituents can be different because it's a class of interventions. Public health interventions can be defined differently from study to study. And some had just a few minutes of face-to-face contact at the beginning, and some had up to the maximum of 10, and that could contribute to why an effect is in the positive direction as well. In terms of the controls, each study had a different usual care definition. So it wasn't like a clinical study where you have a placebo and the placebo is the same in every study. And the outcomes, most of them were biochemically validated, so objectively measured, but a few studies relied on self-report. So that will also contribute to where that black square ends up for a study. So all these factors can have a contribution, and that's why we might expect to see quite a bit of variation. So the way I try to explain random effects models and fixed effects models to the students is to say, well, imagine you've got 5 studies on the left of equal size, then we might sort of see them arrayed left to right with this particular amount of variation. And let's imagine that that's the appropriate size of appropriate amount of variation for studies where there is an underlying common effect that's generated the forest plot. And we're trying to estimate the underlying effect, and essentially the variation that we see between the 5 studies is simply about within-study sampling. Who we get in a particular study is going to vary from study to study. That's going to cause some degree of variation between the studies, but that's caused by the within-study sampling. And that sort of represents the fixed effects model, and we can pull the information from these studies and come up with a pooled effect that answers our question about what is the underlying effect in that sort of question mark box. The random effects model, though, I say, well, each study is quite different from the other studies. They're not the same interventions quite, and so we would expect that the effectiveness of them is actually going to be different in the wider population, the population effects. There are between study differences. There's a level of variation at the top, and so the true effects are going to be different from each other, perhaps represented by this normal distribution. And then under each of these real question marks that underlie each of the interventions in these studies, there's going to be this within sample variation applying, but in a different place, and that causes the extra variation. And so we end up with a wider diamond at the bottom of the forest plot, and that feels like a good thing because it reflects the fact that there is quite a lot of extra variation that we need to capture. If we roll out an intervention, we need to also be aware that where we're rolling it out, because the effectiveness might differ from place to place, so that between study element is very important. If we analyse that data on the right using a fixed effect model, we'd come out with the same answer as we would on the left, so it would be an inappropriately narrow confidence interval that we would achieve in our estimation. And I think clinical interventions are very much geared towards the left-hand part of the slide, whereas the public health interventions are geared towards the right-hand side of the slide. If you have heterogeneity in clinical studies, meta-analyses, some people take fright and say, oh, let's abandon the whole idea of meta-analysis altogether. We can't even go towards a random effects model at all. Whereas in public health, I think these sorts of interventions, random effects is the model of choice. And we're not afraid of between study heterogeneity, and we're very welcome to incorporate it within our estimation and give more realistic estimates of what the rollout of an intervention might be. So this peculiar study, a sensitivity analysis, is essentially taking the study out. One form of it is taking the study out, and if we take the study out, after omitting that study, essentially we're looking to see what impact has that had on the major estimates and the conclusions. What changes? Well, the Q statistic halves from 28 to 14, p-value goes from 0.002 to 0.08, I-squared halves from 62% to 28%. So about, if you loosely speaking, half of the heterogeneity is explained by this very peculiar study that was put in to begin with. The odds ratio itself moves up from 1.83 to 1.99, doesn't move terribly much. This particular study had a very low intervention effect, just under 1. And so by taking it out, the picture goes up. So as it turned out, the picture on the left with all the studies in was a conservative estimate. The funnel plot is another plot that's also used in meta-analysis, and I think perhaps it's sometimes underused, but essentially the information from each study is along the vertical axis. Those are the biggest information at the top. and the odds ratio, the effect, is left to right along the bottom. And the idea is that all the studies should sort of funnel up to give you a sort of estimate of where the underlying effect might be. And there's sort of 3 points that are interesting I found about this particular funnel plot. Firstly, here is that very peculiar study with those extra people in with the higher event rate, and possibly if we were able to cut out those people, we would have brought that dot down, and also the event rate would have come down as well, because I think the people that got cut out, would be able to get cut out, would have been those that were quit at the beginning, contributing to a high quit rate at the end. So I think that dot would have come down quite a bit. And I think it also, adding in a lot of people who have already quit up smoking is going to water down the effect that you see in those that are genuine smokers at the beginning. So I would have thought that dot would sort of shift a bit to the right as well. So probably move right and go down. Another effect that was interesting was there's an indication that there may be publication bias, because there should be symmetry in this funnel plot. And the ones with more information have very precise estimates at the top. The ones at the bottom have less information in them and more variability in their estimates. So you tend to see smaller studies with less information having much more spread in their odds ratios. But if you don't see symmetry, then that's an indication that there may be publication bias. So if you put in a couple of extra studies on the left where that 2 was, and corrected that study at the top to be down a bit and right a bit, probably they'd compensate for each other, you'd get a similar sort of estimate. If you had used the fixed effect model, you'd have had quite a different situation. This very dominant study, the largest study, would have drawn the effect right down to 1.38 with a over-convincingly narrow confidence interval ranging only from 1.15 to 1.65. Very narrow, and many of the estimates from the other studies are well outside that range. Again, indicating that you need to account for this heterogeneity to get reliable estimates with wide enough confidence intervals. The weights under the models, it's quite interesting. We use the DerSimonian and Laird model, a very commonly used random effects model available in most software, and it weights by the inverse of the variance of the estimate. And also the fixed effect counterpart similarly just uses that within sampling variance. Well, if you sort of order the studies from most to least information, then it turns out by the definition of the mathematics of it that you always end up weighting them in the same order, the studies. It's just simply the weights that are given that will vary from model to model. So the fixed effect weight actually gave about 40% weight to that single study, which was largest and also had high event rates. Obviously, studies with more event rates higher event rates tend to be more powerful than studies with low event rates. So it was a double whammy. There's both big and high event rates. So fixed effect weights by the precision, and the random effects model accounts for the between study variance. Okay. So currently I'm quite excited about a particular bit of research that's going on with a colleague at Imperial, Joanna Vasconcelos, and Rebecca Turner at Cambridge. We're going through a very large set of Cochrane reviews and trying to find studies that have missed out a study altogether from the meta-analysis because they weren't able to find a particular statistic such as a standard deviation. And we're trying to develop statistics to tell us how influential these studies might be for reviewers who are having to exclude these sorts of studies. Recommendation is to impute, but it's not always done. And I think, again, sensitivity analysis is very important in this area. If you do imputations, it makes assumptions. If you leave studied out, that makes assumptions. Whatever you do, you probably ought to involve some kind of sensitivity analysis. Yeah. So when I end up with my master's students, I say to them, systematic review is a really thorough thing. If you do a Cochrane review, it could be about a 100-page document, that your protocol, but defining things up front is a very good practice with a protocol, not just in a study but also in a review. The emphasis often with intervention research is on randomised studies, and often they're enough. If there are enough of them, that's fine. And that's because, as we all know, they have fewer types of biases, less selection bias, for example. But trials are trials, and they vary in their quality. Just because they're randomised doesn't mean that's going to be great evidence. And so there's often a lot of effort rating the quality of trials to be able to have a better perception of what the results give. Random effects model, I say, is a good choice in public health. I remind them that the pooled effect is a sort of estimate, it's not the whole answer, there's often a bit of variability around it. I remind them that the forest plot is a very key plot. It shows up heterogeneity as well as the effects, and I remind them that they can actually set out to do more types of they can incorporate more objectives which they can answer with sensitivity and subgroup analysis. They have to be aware of potential publication bias, and I always remind them to be very cautious interpreting negatives. So a so-called negative can actually be a very wide confidence interval representing lack of evidence, lack of information. And I'll just finish up with this slide. I'm not going to say much along it, but I think these have probably been some of the developments that have happened over the 15-year period since the group started up to now. And this is my very selective collection of articles that I've found very helpful and interesting, that cover a wide range of areas. That are the top half are to do with the nitty-gritty of doing meta-analysis, and the bottom half make use of data in more comprehensive ways, trying to do meta-analysis across randomised trials and observational studies at once, which is heresy to some people, but not to other statisticians. Evidence synthesis is has been a very growing area over this period, building models that incorporate evidence from multiple studies, extending the idea of meta-analysis beyond a single outcome to bivariate and multivariate outcomes. And there's been a lot of recent work on Mendelian randomisation and meta-analysis, and in observational research, how to account for missing confounders. Well, thank you very much.